Alrighty, so my name is AJ Agha. I'm one of the new spine fellows. We're gonna get started with our indications topic conference today, which will be on neurogenic claudication, lateral stenosis, and we'll also touch a little bit on foraminal stenosis. Thank you all for coming here today. So here's a brief outline of what we'll talk about today, kind of going from the history, epidemiology, all the way down to kind of treatment options and the supporting literature. So we'll start with some definitions. Lumbar spinal stenosis is a reduction in the volume of the central spinal canal, the lateral recess, or the neuroforamina that decreases the space available for the thecal sac and or the exiting nerve roots. And these have variable presentations in terms of their kind of overall gestalt when they come to your patient clinic. Some may be asymptomatic, some may have low back pain, others have a component of radicular pain, neurogenic claudication, or a combination of those, which we'll kind of dive in deeper to later on. And so spinal stenosis, in terms of its prevalence and impact, is a very common entity that we see and has a pretty large financial impact on society more broadly. It's the most common reason for spine surgery in those about 65 years old. There's over 500K laminectomies performed each year, and about $1.4 billion lost of work hours each year. So this is quite a financially consequential entity that we see. So this is the overall kind of degenerative cascade that leads to the stenosis. So you start with essentially degeneration, which essentially destabilizes the anterior column, leading to some collapse. This then transmits abnormal forces to the posterior column, which means they have to start kind of dealing with more load than usual. And you get ligament buckling, facet hypertrophy as a response, and this forms osteophytes and plus or minus alveolar cysts. All of these factors kind of combine to shrink the size of the canal over time. Other causes and contributing factors include spondylolisthesis, so if the vertebral bodies are unstable, as you can see in the image on the right, the L4 slipping on L5, that can decrease the area of the canal. Other congenital issues such as achondroplasty or congenital spine anomalies, essentially the failure for the posterior elements to develop over time, can lead to congenital stenosis. Again, synovial cysts, as we've mentioned before, and you also have other causes that are listed there. And this is just a small study that was looking at the morphologic differences between those patients who had acquired lumbar stenosis and those with congenital stenosis. Essentially, they considered an AP diameter of the canal of less than 15. And you can see here by the table at the bottom that the difference in these patients is really driven by the pedicle length, and not so much some of the other causative features of stenosis that we see in the acquired group. And so you're essentially dealing with pedicles about 3 millimeters shorter in those with congenital stenosis. As you can see, that can be problematic if these other things also start to hypertrophy over time. And so here's just a quick overview of the regions of the stenosis to kind of better orient ourselves. The lumbar central stenosis refers to anything that decreases the area of the central canal, the thecal sac. They're listed in the red on the image on the right, or sorry, on the left. The lateral recess region is in the green, and then the neuroforamen is that in the yellow. And you can kind of see this axial cut then transmitted into a more of a sagittal-based cut, coronal-based cut on the image on the right. And again, as for central stenosis, our contours of this region are the disc space, vertebral body more anteriorly, the ligamentum flavum more posteriorly, the facet joints posterolaterally. And you can see that etiology of this stenosis can be the broad disc bulges plus the ligamentum flavum hypertrophy, and as well you get facet overgrowth. And you can see on the right how that constricts the canal diameter. And the clinical presentation of this is often presented 90% in those at the L4, L5 region. L3, L4, and L5S1 are about 5 to 10%. Of these patients have neurogenic claudication symptoms, plus or minus a radiculopathy component, and they may be associated with degenerative spondylosis as well, or scoliosis. So briefly, our workup of these patients include detailed history, which not only includes the basics like region of pain and chronicity, but also should ask questions related to the alleviation of symptoms with different postures. And then physical examination should also include the basics of spine exam, as well as special tests like the straight leg raise as well. This, in terms of imaging findings our imaging modalities, we often start with x-rays, and these are often in conjunction with flexion extension films to see if there's any instability at the regions that may be causative. CT scans often are helpful for better Understanding the bony anatomy, see there's calcified ligament, understanding the facet overgrowth and vascular disc phenomena which may present along with these patients. MRI is often very standard, just to better get an idea of the neurocompression at these sites. In terms of injections, these are often transforaminal, which tend to be somewhat diagnostic in terms of deciding which level may be the one that's causative. And then you have interlaminar, which is a little less specific as it kind of flows up the epidural space, and then that could be mostly a therapeutic modality. So looking at the presentation of patients with neurogenic claudication, about 93% of these patients present with low back pain, 63% with about numbness, and 43% weakness. Again, you see the kind of causative etiology of this is the stenosis decreases the perfusion and or the venous return to the area, which essentially creates an O2 demand mismatch when patients are up and moving. And so the kind of classic distribution of pain is low back pain, bilateral back pain, and particularly bilateral posterior thigh pain. This is exacerbated by standing, walking, and anything that kind of puts the lumbar spine in extension. Patients will often describe that they feel better when they lean forward or sit down. And these neurologic exams usually have either wide-faced gaits, or they can have blunted deep tendon reflexes as well. It's important to distinguish this entity from vascular claudication, as they have kind of similar presentations in some degree, but you want to make sure that you're not getting confused by this, because this obviously could, make a bad indication for surgery if you were to proceed with a patient with vascular claudication. And there's just an image on the right, kind of showing the different postural differences in patients with the neurogenic claudication, and then the grid there kind of gives you a delineation between the symptoms between those two entities. And in terms of classification, central stenosis, there's been quite a lot of different ones that have been posited and forth. However, none of these are really all that helpful or useful, generally speaking, because they don't usually predict treatment or outcomes in these patients. And therefore, we kind of generally look at the amount of effacement of the CSF around the nerve roots. As you can see, kind of an image on the far right, you see with increasing stenosis, you see less visualization of the CSF around the nerve roots. And then in terms of the narrowing of these patients, especially with different types of positions, the Penning paper here essentially showed that with progressive narrowing implied that even with patients who had progressive narrowing had more stenosis as they went into extension. So here you can see the image on the right with group 1, the control group. There was about a 9% difference in the canal diameter with flexion extension, and then kind of leading that all the way up to group 4, the most stenotic group, there was a 67% relative difference in the canal diameter with flexion extension. So overall, the most stenotic patients were also the most stenotic in flexion or extension compared to the other groups, but the relative change in canal diameter between flexion and extension was more dramatic in the most stenotic group. Here's just a visualization of that paper, kind of showing the difference in the canal diameters between the normal spine and the stenotic spine with different positions. Now moving on to lateral recess stenosis. Lateral recess stenosis borders essentially are the vertebral body anteriorly, the medial wall of the pedicle laterally, and then the ligamentum flavum and SAP posteriorly. You can see that kind of outlined in the circle there on the far right. And then the etiology of this is the facet joint hypertrophy, essentially that the joints overgrow. You get osteophytes, you'll get synovial cysts as well. You can also be in conjunction with herniated discs that squeeze down that space. Also, you can have spondylolisthesis, which essentially closes that space down as well with the vertebral body motion. And clinical presentation, you see about these are affecting mostly the L5 and S1 nerve roots most commonly. You get nerve root compression either unilaterally or bilaterally, and there's a variance in symptoms depending on the pathology that you see there. So there's been different ways of trying to quantify the lateral recess stenosis. In this paper by Stewart, they aimed to define lateral recess by essentially these different height and depth and angle markers. You can see there with the lateral recess height of less than 2 between SAP and the posterior border of the vertebral body, a depth of less than 3 millimeters between the SAP and posterior vertebral body and the cephalad border of the pedicle, and then lateral recess angle of less than 30 degrees. As you can see, these are all drawn out there in the images above. But again, these all had pretty poor correlations with patient symptoms and did not necessarily help guide their treatment. And so this is a study that looked at symptom induction in both lumbar flexion and extension. For flexion, extension, or both flexion and extension, patients with herniated discs were significantly more likely to have symptom induction compared to those with lateral recess stenosis. But I think it's important to look here at the age differences here in which those two things are being highlighted, showing that lumbar disc herniation was much more common in those in their 40s compared to lateral recess stenosis in those in their 60s. So to kind of know which age groups you're seeing in patient to kind of get a better idea of what may be causing their symptoms. And so diving into some of the treatment options, like all things in orthopedics, we start with non-operative management first. So this includes your physical therapy, your medications, activity modification, different types of bracings. We do see the use of epidural steroid injections, which may give short-term relief as well. But especially these patients, at 10 years, they show that about, kind of categorize them into 1/3. So 30% improve, 30% remain unchanged, and about 30% clinically worsen. So the surgical indications are for those who have failed non-op management. And then you also have imaging confirmed with moderate to severe stenosis or worsening with neurologic symptoms. And also if you have patients with mobile spondylolisthesis, but this will be covered in a different lecture. And so these are kind of our main workhorses for dealing with central lateral recess stenosis. You have your laminotomies, which essentially spare the PLC, and you can maintain your posterior stability, especially if you don't take more than 50% of the facets. You have low reduced postoperative pain, low risk of dural tear. And then you move over to your laminectomies. Again, this is a little bit more invasive, essentially removing the posterior complex. And so you have a increased risk of instability, especially if you take more than 2 levels. And then these patients do have some higher postoperative pain compared to the laminotomy, a higher risk of dural tear and epidural scarring. And another modality is the MIS tubular version, which essentially just use dilating tubes over the area of decompression. And the idea is to essentially spare some of the soft tissues with this. There have some studies that show some longer OR times, but less overall blood loss. They do have a shorter post-op recovery time, but essentially equivalent neurologic outcomes with the other modalities. Sometimes there are some issues with visualizations since you're looking down a long tube. So it does take some practice to get facile with this. So here's just an image showing a decompressed kind of lateral recess in areas that you show that you're decompressed all the way out to the medial pelvic wall. You can see the dural sac there kind of more on the bottom of the screen, which would be more medially, and then the traversing nerve root. And so it's good to make sure that you have a proper decompression out to the medial pelvic wall. So here's just some keys to success to do this. So again, essentially making sure that you're identifying and removing the offending pathology, whether that be kind of overgrown SAP, whether the patient has an associated herniated disc at that level, and then also if they have any cysts that are in the region that could be impinging on the nerve root. So again, ensuring decompression to the medial wall, and essentially, but making sure that we're not going to destabilize this level of the spine here by taking too much of the facet. So usually a good rule is to not take more than 50%, as to not increase the risk for instability. And here is just a couple other notes. I think just understanding the patient-specific anatomy. These are just a couple screen grabs from a couple cases I had with Dr. Stefan earlier this year. Essentially, wanting people to understand the patient-specific anatomy for safety reasons and to obtain adequate decompression without risking instability. So the patient on the left side of the screen, it's kind of a more normal angle to the lamina. So only needed to kind of decompress about 1 centimeter laterally based on his morphology. However, the patient on the right had a much more kind of sagittally oriented lamina and facet joint. So I needed to keep that in mind when burring that I can't go as far lateral as the first case, risking the instability as well. There are some other treatments out there as well. This is, there's some use of interspinous, essentially spacers or blockers, and the goal is to essentially block that extension moment, which decreases the spinal canal diameter. Not really directly depressing anything, but these do have a pretty high rate of revision. And then patients who may have some aspect of essentially instability of their spine may need decompression and infusion. to essentially lock down that area. So here's a sport trial that's often cited. This is kind of the landmark RCT that used to evaluate the effectiveness of surgical intervention for the three most common spinal pathologies, which included the lumbar spinal stenosis without spondylolisthesis. So in the lumbar stenosis iteration, they compared surgical intervention in the form of decompression versus various non-op treatment. And it's about they had 654 patients in total were enrolled and randomized into the cohort. And in about 2 years, 67% of the surgical group had undergone surgery, and 43% of the non-surgical group had undergone surgery due to large and non-adherence of both the groups of the randomized arm. They essentially had difficult power to treat intention to treat analysis, which was significantly impacted. So, in their combined as to treat analysis, they did find statistically significant improvement with surgical intervention compared to non-op, with greater improvement in pain, function, and satisfaction, as well as self-rated progress than the patients who did not undergo surgery. And this is the 8-year data in the as-treated analysis combined with the randomized and observational cohorts of the patients with lumbar spinal stenosis. Those treated surgically showed significantly greater improvement in their pain, function, and satisfaction, and self-rated progress again at 8 years. And so the surgery group that you can see there shaded on the circles on the right, and the non-operative group was the shaded triangles there on the right. And in this study by the Canadian Spine Outcomes Research Network in 2019, they also looked at patients with lumbar spinal stenosis, back pain, and neurogenic claudication who underwent decompression. They showed that at 2 years, about 70% had improved leg pain, 68% had improved back pain, 41% had minimal pain overall. These results were similar with or without fusion. Essentially, this also highlighted patient factors being predictive of achieving the MCID and low back pain postoperatively. These included the absence of narcotic use, the absence of any compensation claims, as well as increasing low back pain severity before surgery was completed. And here's just another study which looked at essentially the different types of minimally invasive techniques to address the lumbar spinal stenosis, everything from unilateral laminotomy to bilateral to spinous process osteotomy. Essentially, what they showed that there were really no differences in the overall outcomes. In this study, the primary outcome was the ODI. And so they also showed that there were no changes in the secondary outcomes really either. And so these are all pretty equivalent outcome measures when they looked at the different modalities used to treat this condition. Now, briefly spending some time on foraminal stenosis. And so this is, again, a little bit more lateral to the lateral recess that we talked about previously. And so this is kind of the borders there are listed the vertebral body anteriorly, the pedicles superiorly, inferiorly, the ligamentum flavum and posterior, epicet posteriorly, and then the upper lumbar region has more osseous coverage of the foramen. In terms of its etiology, you'll have disc degeneration, osteophytes, as well as issues with spondylolisthesis and scoliosis, which may cause the foramen to stenose or become smaller. And again, these are sometimes dynamic in nature, which we often will assess with FlexX films as well. And so these often are affecting the L5 nerve roots and the L4 nerve root most commonly. And you can see just a schematic of the zone there with essentially normal foraminal height, usually around 20 to 23 millimeters. And here's just another good X-ray image and then MRI image showing the foramen and the spaces there. The image on the left, you can see the open foramen between the pedicles there. And then the image on the right shows the MRI, usually assessed by T1 image. You can see that the nerve roots are those black dots. And then you can see with the increasing stenosis, the effacement of that perineural fat. Essentially, the red arrow showing complete effacement, and then the yellow arrow pointing to an area that has moderate effacement there. So again, the treatment options somewhat mirror those that we're seeing in the other types of stenosis, again, starting with non-op management, and then going into surgical management if they failed non-op management. Usually about 3 to 6 months of non-op management is indicated. or if they have a progressive neurologic deficit, especially with weaknesses involved, and then must have image confirmed with moderate severe stenosis as well. So the different types of modalities used to treat this entity both include direct decompression, kind of in your forms of foraminotomies, fatectomies, combined approaches of these, and then also indirect decompressions with often the use of interbodies and fusion, and obviously have your MIS and tubular modalities as well. So this was a paper that looked at indirect decompression. It was in 2021. They essentially investigated the use of ALIF procedures and whether they could provide safe and effective indirect foraminal decompression. And so they radiographically reviewed post-op X-rays, looking at the foraminal height and area. They only really were assessing the L5 S1 area, but they excluded any patients who had spondylolisthesis or severe stenosis. And you can see here that ALIF did provide significant indirect foraminal decompression and improvement of the radicular pain, and that the increase in the foramen height surface and the posterior disc height was directly associated with the improvement in the radicular pain. So the image on the right just shows the two pre and post-op images. You can see the increase in that blue outlined area, essentially indicating the increase in indirect decompression with the interbody there. And this is just a couple of slides from a ALIF review paper that helped write a little bit earlier this year to residency, which essentially discussed that if you are going for indirect decompression, you need to make sure that you have good interbody placement and that you're not either overstuffing the area, which could induce a neuropraxia, or putting in a cage that's too lordotic and essentially inducing a reciprocal hinging down of the posterior elements and squeeze down the foraminal space, which you kind of see on the image on the left, where it was too large and a little bit too lordotic, and essentially was squeezing down the space that we were actually intending to open up. So making sure that you're assessing these on C-arm is a good idea. And then also making sure that if you are looking to do an indirect decompression on the patient, you need to make sure that there's a thorough evaluation of their vasculature and their other anatomy to make sure that the region that you want to indirectly decompress is accessible. And the panel on the far right is essentially showing that if you were trying to go for the L4 disc space, it may be quite hard, given that you have essentially a smattering of the different vessels layered on the top of the disc space there. And then just a quick touch on the endoscopic treatment. This is an article from the Journal of Clinical Neuroscience. Authors evaluated the radiographic outcomes of endoscopic transforaminal foraminotomies at L3, 4, 4, 5, and 5S1 on cadavers, and they used pre and post-op CT scans to essentially measure the difference in the foraminal height. You can see the images on the far right showing the different overlays and seeing how much bone was actually removed compared to the pre-op CT. And you can see that 12 to 40% increase in foraminal height and about 35 to 99% increase in the foraminal area. And so they essentially concluded that you can get decent decompression of the foramen using this technique. And then this is just another study that evaluated the overall effectiveness of endoscopic decompression. And in this study, they showed that patients had ODI and VS scores improvement that exceeded the criteria for the MCID. And essentially saying that the full endoscopic interlaminar approach took about 51 minutes in total. And so just to kind of close it out, again, if you're looking for indirect decompression via interbody, you look to restore the foraminal height in the central canal area as well via disc hernia, essentially disc height restoration and sucking in the annulus. It can also improve ligamentous buckling as well as improve the interpedicular distance. And with direct decompression, you may need to do this when you think that indirect decompression may not give you enough, especially if you have other pathology in the region, such as we're going for sets, things like that. And so these are all components of the treatment options that should be considered when dealing with this entity. So that's about it. Thank you all, and any questions?
Nice job, AJ. Big topic.
A big bite of an apple. The endoscopic thing I think is really interesting now, especially for central stenosis. I think, if you guys are interested, we'll keep setting this stuff up throughout the year to get your hands on those techniques. I know you guys hopefully got your hands on it this weekend. But if you didn't, I think be on the lookout throughout the year. We'll probably have a couple of labs on endoscopic cases, that kind of thing. So, interesting world.
Nice job, AJ. I think it's just important to like you went through everything when you see patients in clinic and when you're looking at imaging, like figure out what their problem is, and then from where their problem is coming from, then you can figure out your solution, right? So if you have somebody with central or lateral recess stenosis, you're like, okay, well, I can do something central or lateral recess to fix the problem, right? Or hey, this person has foraminal stenosis. This person needs a different type of technique. So I think it's easy to just kind of break it down. It gives you an algorithm to work through in your head, but it's not. People can have multiple things, right? They can have foraminal plus lateral recess, and then you can say, well, I think they're L5 roots, which pretty severely at 4-5 in lateral recess. That's probably not the foraminal part. So then you can even consider doing something smaller than doing a fusion down to 5-1. So just break it up in your head. It makes life a lot easier.
I know that there's different maybe thresholds, or I guess my question would be, are there any kind of buzzwords in clinic that a patient will give you to think that they may be someone who's more amenable to just an indirect decompression, especially if their imaging is a little bit equivocal in terms of how much stenosis is coming from the posterior elements. Is there different things that you use to kind of suss that out and to be able to decide what patients may be okay with just an indirect decompression versus also doing a posterior direct decompression?
I think you can talk to them, especially if they have like a spondy that's mobile. You can always talk to them about like how they feel if they're laying down, because that's when they reduce a little bit. So right, so you can tell if they're laying down and they reduce and they feel better, then you may not need to do a direct decompression. But as you get more kind of reps with these patients, you'll kind of start to realize, like, where you saw a bunch of those far lateral disc herniation people come in and they're just miserable, right? So there's a little bit of different flavor, but oftentimes this stuff all presents the same, and it's up to you to figure out, what's the puzzle, what's the answer here, and it may mean treating everything, it may mean not treating everything. So